All right, thanks, Dr. Barbu. Well, as Dr. Barbu told us, my topic is going to be sleep in Parkinson's disease. And as you can see here on the slide and how I've titled it, this is a really significant issue in Parkinson's disease, and I think it's been touched on in a couple of lectures already. So this is my disclosure slide. It's more disclosures and conflicts of interest. I've done speaking engagements for a couple of different medical companies and some consulting for some medical companies, nothing recently, nothing that would have any relevance to this talk. So this is an outline of my talk. I'm going to talk about the overall importance of sleep. I'd like to talk about some of the sleep changes in Parkinson's disease, briefly on some diagnostic workup that your doctors may do. Then I want to talk about some of the treatments in Parkinson's disease, both from a lifestyle standpoint and from a medication standpoint. And then we'd like to give some overall conclusions. So these are my questions. I'm going to give you guys a little bit of time to look at these before I keep going. Okay. So one of the big things about Parkinson's disease is your general health is really important. And a big aspect of general health is obviously sleep. And so something I always tell my patients is if you don't sleep well, you often don't feel well. And that holds true for a variety of things besides sleep. You know, we've talked about exercise a little bit. We're going to have a specific talk on exercise after mine. You know, controlling your general medical problems, diabetes comes to mind immediately, back issues, orthopedic problems, and also, you know, eating healthy. I mean, all these things are important for Parkinson's care. And so, of course, I'm focusing on sleep in this talk. You know, we being collective, the scientific community has been looking at sleep for a long time now. And, you know, we don't fully understand it still. We're still looking at it. But we do know it's important for adequate health, it's important for recovery from daytime activities, and it's involved in a variety of different bodily functions. And we also know that sleep is a little bit complex. You go through different stages of sleep as the nighttime progresses, and you actually cycle through those stages quite a bit, anywhere from 4 to 6 times a night. There are 3 what we call non-REM stages, and as you go up in those REM stages, non-REM stages, you go into deeper and deeper aspects of sleep. And then you have what's called a REM stage, which stands for rapid eye movement sleep. This is a really fascinating stage, and it's got some unique abnormalities in Parkinson's disease and some related disorders. But in rapid eye movement sleep, there's a lot of dreaming. We also think it's important for cognitive function. And during REM sleep, in normal REM sleep, you're supposed to lose or partially lose motor function. So you have semi-paralysis of your arms and legs. And there's a unique thing in Parkinson's disease called REM sleep behavior disorder, where you actually lose that paralysis and patients will actually act out their dreams at night. And I'm going to talk about this quite a bit in my lecture. So, importance of sleep. So what we've also found in Parkinson's disease is that the more important stages of sleep are actually the ones that are more affected. So we actually see structural changes in those stages, but we also see the time that you spend in those stages is impacted as well. So the deeper stages of non-REM sleep, so what we call N2 and N3 sleep, are affected, and then REM sleep itself is affected, which I was kind of touching on earlier. Total sleep time actually is impacted, and sleep efficiency. So when we talk about sleep efficiency, we're talking about the time you spend in bed, how much of the time are you actually sleeping. That's also impacted. Sleep disorders in Parkinson's disease, as I have here on the slide, are very common, depending on which trial you look at, and that also depends on what stage of disease the trial is looking at. Sleep disorders can range from 20% in these trials to over 90%. And sleep disorders in Parkinson's disease are unfortunately also very complex. Different people have different problems. There's a variety of factors that influence sleep. And so doctors often, it's very difficult to tease out, especially in a Parkinson's visit when you're dealing with a lot of different problems. it's very difficult to spend enough time to really tease out people's sleep problems. So what can sleep or bad sleep do? It's been associated with worse quality of life. It's been associated with disability. It's been associated with worse cognition, with mood problems, as you heard from Dr. Pontone. It's been associated with psychosis and even hallucinations. When we look at studies, people with bad sleep have worse motor scores, and it's also seen more commonly with worse clinical presentations. There's a variety of risk factors that we think can lead to poor sleep. So the things I've listed on the slide here, female sex, longer disease duration, depression, higher Parkinson's disease medication doses, and even hallucinations can lead to worse sleep. So, I was talking about sleep being more interest to the scientific community. It's also more interest to the Parkinson's disease community. It's becoming more of a frequent topic of conversation among physicians. It's also becoming a more frequent topic of research. We just had our annual International Parkinson's Disease Symposium a couple weeks ago, and there were quite a few lectures that talked about sleep, and there were also a few lectures that were devoted purely to sleep. So again, this is something that is really becoming more prominent in the Parkinson's disease world. I always try and do a little bit of research before I do any kind of talk, and one of the things I like to do is look at our online database and just do a search term for whatever I'm looking at. So in this case, I did Parkinson's disease and sleep, and I found over 5,000 articles that met those criteria. So again, there's a lot of stuff out there. A lot of times we'll also do patient surveys, and when we focus on non-motor symptoms, which are the symptoms outside of the movement problems, consistently sleep comes up as one of the areas of disability, either one or two. So it is a big problem. So I'm going to kind of move into the different types of sleep problems within Parkinson's disease, and again, there's lots of different ones, unfortunately. Insomnia is kind of a general term for poor sleep. Typically when we think of insomnia, we think of problems falling asleep and also staying asleep. When we talk about staying asleep, you can have fragmentation during the night, and you can also have problems with waking up too early. Fragmentation seems to be the most common sleep problem that we run into in Parkinson's disease. Patients can also have altered sleep-wake cycles or altered circadian rhythms where they want to sleep during the day and are awake at night. There's also something called advanced sleep phase, which seems to be a big problem with Parkinson's disease patients as well, where they want to go to bed earlier and wake up earlier. I've already touched on REM sleep behavior disorder a couple times, or acting out dreams, and I'm going to talk about this a little bit more later. Some things that can be similar to acting out dreams, excessive nightmares, sleepwalking, and things of that nature can also come up with Parkinson's disease. We see problems with nighttime hallucinations, confusion. Daytime fatigue and sleepiness during the day is a big problem that I deal with. And then there's a couple of things that seem to be possibly connected, depending on which study you read. The evidence is a little bit better or worse. But sleep apnea seems to be a concern with Parkinson's patients, then restless legs or periodic limb movements of sleep. So what causes the sleep problems in Parkinson's disease? Again, we just saw a slide with a lot of different types. So you can have a primary sleep problem where you see changes in the architecture of sleep, or what I would blame specifically on Parkinson's disease. As people get older, they commonly don't sleep well, and unfortunately our Parkinson's population is older. You can have problems where your medicines for your Parkinson's disease are not lasting through the night, so if you move to a lower level of sleep or wake up, you commonly are very uncomfortable and it's harder to go back to sleep. There can be problems with frequent urination at night. This is another big problem that I see a lot of. And then going back again to Dr. Pontone's talk, depression and anxiety is a big problem in Parkinson's disease, and it can certainly affect sleep. Another thing I have on the slide is drug side effects from Parkinson's medications. And again, this is something else that we struggle with. One of the common conversations I have in my clinic as well is, is this Parkinson's disease or is this not Parkinson's disease? And I think it's important with sleep to also think about that. Not everything is from Parkinson's disease. In terms of other things that may impact your sleep that may or may not be related to Parkinson's disease, pain is something I run into. Pain is unfortunately a very common issue with Parkinson's patients, but not all pain is from your Parkinson's disease. You can have problems with hormonal issues or metabolic issues, thyroid dysfunction, sugar issues, postmenopausal issues. All of those can cause problems with sleep. And then chronic medical conditions outside of your Parkinson's disease, so diabetes, kidney disease, respiratory problems, all of these issues can potentially contribute to poor sleep as well. And then we talked about Parkinson medication potentially causing problems with sleep. You know, there are certainly medications that are not directly Parkinson medications that can affect sleep as well or cause daytime fatigue. And so those need to be looked at as well. So kind of building off that, we've already heard several people try to not have busy slides, so I apologize for this one, but I think this really reinforces my point about medications. There's lots of medications out there that can cause problems with sleep. There's several on here that are blood pressure medications that can impact sleep. One of them is certain types of beta blockers. Metoprolol is one I see quite a bit. Clonidine is something I see probably a little less commonly, but it can impact sleep. Diuretics or water pills can cause increased urination at night, which can impact sleep. Steroids are mentioned on here that can cause you to be jittery and it can impact REM sleep. There's several medications that are used for coughs or allergies, which is obviously a big problem in East Tennessee, and so those can be an issue. Antihistamines are mentioned in here, as well as some of these other allergy medications. Then we look at stimulants like ADHD medications. Those can be a concern. And even medications for your thyroid dysfunction can impact your sleep as well. So again, you can see that there's a lot of medications that impact your sleep, so it's important to do a good medication review with your doctor when you're struggling with your sleep. So this is a very basic workup on what someone is trying to address sleep problems would do. So just like with any kind of problem, you want to get a good story. So given that Parkinson's sleep disorders are so complex, the best story we can get really helps us in trying to determine what to address in regards to your sleep. So I've already mentioned several times reviewing medications is important, both Parkinson medication and non-Parkinson medication, to see if something might impact sleep. It's important to discuss sleep hygiene. So this is kind of your basic habits. There's a lot of things that you can do from a lifestyle standpoint that can either improve or negatively impact your sleep. And then I'm going to say this once again, assess for depression. Depression is a big problem in our population, and it can certainly affect your sleep. And then we proceed more to more objective things like checking labs, again, basic metabolic profiles, thyroid function. Testosterone has sometimes been low in men, especially in Parkinson's disease. It's somewhat controversial, but it's something sometimes I look for. If I'm not getting anywhere, then the next thing to do is to refer to a sleep clinic. We have a good sleep clinic here at UT Medical Center. You can look at a sleep study to see if there's some kind of problem specific with sleep at night, like sleep apnea. We also use something called actigraphy, which is putting a watch on someone's arm where you can measure people's sleep-wake cycles, and that can be helpful in trying to impact sleep in a positive direction. So I next really want to talk about treatment. So the first thing is lifestyle treatments or trying to impact sleep hygiene. So I have it in bold at the top, and you're going to hear exercise, exercise, exercise from us today. But physical and mental stimulation is really important. But it's also important to do it at the right time. You want to do it in the mornings or the early afternoons. You don't want to do it right before you go to bed, because that can negatively impact your sleep at night. Caffeine during the day can be helpful. Again, same thing. You want to do it in the early parts of the day or in the early afternoon. You don't want to do it right before you go to sleep. I think we've had a couple talks that have mentioned possibly coffee as being helpful in Parkinson's disease. Unfortunately, in a lot of our trials, once people have Parkinson's disease, we haven't seen a lot of impact on motor symptoms, but it may have some protective effect before you actually develop Parkinson's disease in some of our large population studies. But here, it can be helpful on sleep, so it's certainly not going to be negatively, or shouldn't negatively impact you. We've talked about peeing at night, so it's important to try and avoid liquids right before you go to bed. I mean, your last liquid should really be several hours before you go to bed to try and diminish the need to pee at night. It's always really important to have a set routine. So you want to have set bedtimes, but you also want to have set wake times. And then this is something I actually struggle with sleep. This is always a really difficult thing to do, but if you wake up in the middle of the night and you can't go back to sleep, it's important to try and get out of the bed and do something else. Do something relaxing, but don't just sit there and fight and fight and fight. You're not going to be able to get back to sleep. So go read a book, do something relaxing, and when you're a little bit more drowsy and relaxed, come back to the bed at that point. Your bedroom. Your bedroom should be a place for sleeping, so it should be cool and dark. You really need to remove distractions as much as possible. Get your pets out of your bed, remove TVs from the bed. That's really important. You want to avoid blue screens at night. Everybody's on their phone now, and that can impact your sleep. So don't have phone time at bedtime. Avoid your computer. Avoid other stimulating activities. Don't watch the horror movie or the action movie right before you go to sleep. Naps. I like a good nap too. So it's important though, if you do take a nap during the day, it should be a power nap. This should be like a 15 to 30 minute nap. This shouldn't be the 1 to 2 hour nap. You're not going to be able to sleep at night if you've slept a lot during the day. And then use light and dark to your advantage. So light will stimulate you, and turning down the lights will relax you and help you go more to sleep. So during the daytime, there should be a lot of natural light. The light should be on. And then when you're wanting to tone it down and go to sleep, the light should be off. This is a slide that also is, again, too busy, and I apologize. This is guidance from our International Parkinson and Movement Disorder Society. This is a paper that actually came out in 2019. And what I really want you to see is if you look at the column that says efficacy, which is another word for benefit in the medical world, you can see insufficient evidence almost all the way down there. Rotigotine, which is a medication for motor symptoms, it's a dopamine agonist, is a patch. It's also called Nupro. Seems to have some likely benefit for sleep disorders. The only other thing that you see on there that is potentially beneficial, at least by the study evidence that we have, is CPAP, and that is both for insomnia, and it's also listed there at the bottom for excessive daytime somnolence and sudden onset of sleep. That's very specific for people with sleep apnea. If you move over to practice implications or what's recommended from the International Movement Disorder Society, rotigotine is listed as possibly useful. Ezapicolone, which is also Lunesta, which is a hypnotic, is listed as possibly useful. And melatonin is listed as possibly useful. It's actually approved for insomnia in Europe. Modafinil, which is a stimulant, is listed as possibly useful. And then CPAP, again, specific for those with sleep apnea, is listed as possibly useful. So I guess the take-home point from this busy slide would be that, unfortunately, we don't have the degree of evidence that we'd like for a lot of the things that we use in sleep. We just don't have the studies to back things up. I'm going to move on to another table from that same paper. This is interventions to treat fatigue in Parkinson's disease. And same thing, if you look at the different things that have been looked at, the only thing that's listed as beneficial or efficacious is rasagiline, and the practice implication is it's possibly useful. I don't use as much rasagiline actually for fatigue in Parkinson's disease. I actually like a kind of a twin, or at least a medication in the same class called selegiline. When selegiline breaks down the bloodstream, it actually has an amphetamine byproduct, so I'm a little more likely to use that. But both of these medications are something that we consider when we deal with problems with fatigue. And so the rest of my slides are really going to be looking at the different types of medical treatments that we might use in Parkinson's disease. I've already stated this, but again, I just want to reinforce that there's just unfortunately not a lot of high-level evidence for specific treatments in Parkinson's disease. So because of that, a lot of the things that we use come from the general sleep literature and clinical experience. It also is important, again, that we have to get a good story of what your sleep problem is. Our strategies are really going to vary depending on what we think is the problem with your sleep. So a lot of my next couple slides, at least in part, are based on some of the literature that was reviewed in this paper from 2017 that looked at some of the more prominent studies in the last decade. So insomnia, this is kind of a generalized term for poor sleep. The most common sleep-related complaint underneath insomnia and this in general, again, is sleep fragmentation. And again, depending on the study, you're looking at about 20 to 80%. Treatment is really going to depend on the perceived cause of the insomnia. So I've listed quite a few things out. Urinating at night, off times at night, obstructive sleep apnea, psychiatric concerns, drug side effects, and pain are all very common ones. I found one study that showed that female sex, total PD medication dose, total dopamine agonist dose, more depression, actually better cognition and more on and off actually accounted for about a third of insomnia cases in the study that I looked at. So what do we do? So going back to that earlier slide from our International Movement Disorder Society, melatonin as a PIC clone tend to have the best evidence. When we talk about non-medication options, which is something that is really important, they don't obviously have the side effects that you can have with medications. Cognitive behavioral therapy is something that's talked about quite a bit in the sleep literature. I actually reached out to our sleep center here at UT Medical Center. They do some cognitive behavioral therapy in their center, but unfortunately resources in the Knoxville community outside of just big sleep centers unfortunately are somewhat limited. They're hoping to build that up in the future, so I would really like to use this more than I have been able to at this point. We talked about basic sleep hygiene already on a couple slides. That's really important to reinforce because that can help you. And then long-acting dopamine formulations. Those can be helpful, particularly for off times at night. So we use a variety of things. Rotigotine, if you remember from one of those prior slides, seems to have some specific benefit with sleep. The long-acting oral dopamine agonist, pramipexole and ropinirole, and then carbidopa, levodopa, CR are all things that I use. Sometimes, unfortunately, when you use some of these medications, that can actually worsen sleep. So sometimes it's a catch-22. So you have to kind of really figure out what's going on with someone's sleep. Often it's trial and error. And then there's actually also medications that can increase hypersomnia, or excuse me, I misspoke. They can actually disrupt your sleep and actually make you more awake. So we've already mentioned selegiline and rasagiline is something that may give you a little bit of energy. Amantadine has a lot of evidence of helping with energy during the day in a variety of neurodegenerative disorders, and even entacapone has been shown to maybe increase some energy. These can be great in the earlier parts of the day, but certainly not something you want to take right before you go to bed. Depression medications. So once again, depression can be a big problem with sleep. In terms of direct treatment of depression, the best evidence we have from our Movement Disorder Society is actually in venlafaxine. It is listed as clinically useful. The other one we have is actually pramipexole, which is one of the medications we use for movement problems. Right now, a vast majority of the rest of our antidepressants are listed as possibly useful. I thought some of the evidence on paroxetine and nortriptyline was a little bit better. But again, the only one we actually have that's listed as clinically useful is venlafaxine in the antidepressant world. So I will use a variety of medications to treat depression, but in terms of depression medications specific for sleep and not necessarily for depression, we use quite a few. Trazodone, mirtazapine are probably the most common. I've used a lot of doxepin recently. Nortriptyline and amitriptyline are also medications to think about. Antipsychotics. So we sometimes use antipsychotics specifically for sleep. I don't tend to do it very often because of some of the side effect potential. But if patients are having hallucinations at night, it's not uncommon for me to try quetiapine. I think that's a great option. One of the side effects is it makes you drowsy, and so that can really help people sleep at night. There's also the primary sleep aids, Dolpidem, which is Ambien, Zaloplan, which is Sonata, I believe, Temazepam, and then I can never pronounce this, Ozapipclone, which is Lunesta. I don't use a lot of the first two. I don't really like benzodiazepines, which is what temazepam is. I've started to use a little bit of Lunesta given some of the recent guidelines from the International Movement Disorder Society. These can have side effects, so I'm cautious with them. The next category I have listed there is further benzodiazepines. Again, I'm just not real keen on the benzodiazepines if I can avoid it. They can have problems with cognition. That can increase your fall risk. I really don't use alprazolam. It's pretty short acting. Clonazepam is a little more longer acting. That's probably my go-to if I have to use a benzodiazepine, but it's not my first thing to try. CBD, I get asked about this quite a bit. There is some building evidence for some assistance with sleep and maybe pain, but definitely the research is mixed. High-quality trials are also very limited. There was actually a trial that came out about 2 months ago, I believe, in our big journal. It was looking at CBD specifically for REM sleep behavior disorder. It was not a positive trial for that, but they did show some benefit in sleep quality potentially. At least that was per patient response. And then lastly, I have on here is deep brain stimulation. I certainly would not do deep brain stimulation to help your sleep, but just know that if we do think you're a good candidate for deep brain stimulation, patients do sometimes see some impact on their sleep in a positive direction. There's potentially a lot of reasons for this. One of them may be that we're giving you some therapy at night when you're sleeping. Obviously, you can't take your oral medication, so this does provide you some continuous therapy benefit. Urinating at night or natriuria. So this is a common problem. We see this in up to 2/3 of patients with Parkinson's disease. In terms of risk factors, it seems to be common in men, older patients, older age at Parkinson's onset, a longer disease, more severe disease, and then higher medication use. How do we treat it? So again, like to start with lifestyle if I can. Limiting liquids several hours before you go to bed is very important. A bedside commode, even Depends can be used. Mirabegron, which is Mirbetriq, is probably my go-to. I really like this medication in terms of the side effect profile. In terms of their package insert, hypertension or high blood pressure is listed, but it does not cause the kind of issues that we see in a lot of the other bladder medicines. And those are what we call anticholinergics. We used to think that these medications cause short-lived cognitive problems, where if we stopped them, the cognitive problems went away, and that does happen in a lot of cases. But we have seen quite a few studies recently in the last 5 years or so that have shown that if you're on these medications, when you come off of them, the cognitive problems may be more long-standing. So we're very careful with these medications if we can. The ones I like to use are ones that are more limited in crossing the blood-brain barrier. Trospium I really like, and some of these other ones here listed. Unfortunately, sometimes they're harder to get approved, but these are the ones that I would prefer to use if I have to. If I'm not getting anywhere, there's always the urology referral. That can be very helpful in further guidance with Parkinson's and non-PD causes. I can give you some advice on medical interventions, and there's also procedural interventions. So bladder stimulators are sometimes used. Posterior nerve stimulation, I've seen a lot more people getting this done where they stimulate your posterior tibial nerve, and it actually sends a signal up to the sacral plexus, which is involved with bladder function. Fatigue and excessive daytime somnolence. So again, percentages vary pretty widely, but anywhere from 20 to 60% for some of these studies. And again, I'm going to read off some of the risk factors. So older age, male sex, cognition, other sleep disorders, mood disorders, disease severity, disease duration, medications. All of these can contribute to problems with fatigue and excessive daytime somnolence. And we've already seen a couple slides now on different medications that might be doing that. I've also started to see more evidence that daytime fatigue may be a harbinger of Parkinson's. We already talked about depression and anxiety. I think some of these other talks have looked at other premotor symptoms. So daytime fatigue may be an additional one as well. So how do we treat? Exercise, exercise, exercise. Again, it's really important to do this during the early parts of the day. Don't want to be doing it right before you go to bed. Sometimes I'll employ energy drinks. I encourage people to drink caffeine more towards the earlier and middle parts of the day. And then, of course, review medications. Again, we've talked about this ad nauseum at this point, but making sure you go through your non-Parkinson's medications as well as your Parkinson medications. I worry about anticholinergics. I wrote down dopamine agonists. Those are probably two of the medications I worry about the most, but I hear all the time that patients taking carbidopa, levodopa, get sleepy on that. So most of our Parkinson medicines, unfortunately, can cause some level of fatigue. PD medications to try, we mentioned rasagiline on the list of recommended medications from the Movement Disorder Society. I tend to like to try selegiline and also amantadine in the Parkinson's world to see if it'll help fatigue. And of course, these medications are for motor benefit, so it has that additional benefit of helping your motor symptoms as well. Stimulants, I have a hard time getting some of these approved unless you have obstructive sleep apnea, but I try a modafinil or a modafinil. Methylphenidate, which is Ritalin, is something I've tried on a couple of occasions. I have a couple of people that take this. This is something to think about. At least per our Movement Disorder Society guidelines, modafinil has the highest recommendation at this point. There's a couple other medications that have not had as good a study, sodium oxybate, toxametine, which is Strattera, which is also an ADHD medication. There's some evidence behind that. They're still being studied. Bright light therapy, which is something I actually don't know that much about. I've started to see a little bit more in our literature. Bright light therapy may have some benefit for motor symptoms, for mood, and also for sleep. There's a couple studies that have come out now, and I looked at clinicaltrials.gov. I found at least 2 or 3 studies that are being done right now. I guess there's a lot of questions right now. How much bright light to use? You should typically get them in these boxes, or get these boxes that actually will shine bright light in your eyes. Also, the question is when to use the therapy. A lot of the trials have used the bright light therapy at night, like 1 or 2 hours before you want to go to bed, because patients have this advanced sleep phase problem where they want to go to bed earlier and then wake up earlier. So you use the bright light to kind of push the sleep phase back. But there's also been some trials where patients have been using this in the early mornings. This is something probably I'm going to be looking at more. Again, I think the nice thing about lifestyle management and things like bright light therapy is it doesn't have the side effect potential that some of our medications do. Certainly in someone that has mood problems and has sleep dysfunction, this may be something to think about because it does seem to have some impact on mood as well. And I guess I should mention just as before I move on from that, I talked to our sleep center about this as well because I was interested in it. You can get some of these bright light boxes fairly easily from Amazon. There's other vendors. In terms of people doing this actively, like a sleep center, that is not as accessible right now. But it may be worth it if you have problems with sleep and you are established with a sleep center. It may be worth something or bringing it up. Hallucinations at night is my next topic. So again, it's going to depend on time course in your disease process, medications, but percentage of hallucinations and delusions vary considerably in the studies, anywhere from 20 to 70%. I've already mentioned this, but medications and disease progression are going to have a lot to say in whether or not you have these problems. In terms of treatment, donepezil and rivastigmine are 2 of our more common cognitive medications. You certainly can try these. I tend to, if I'm talking specifically about sleep, I tend to like a couple of the antipsychotics, quetiapine and clozapine. Both can have a sedating effect, so they can be very useful at night. Clozapine is a little bit harder to get, and you have to have routine blood draws, so I tend to really focus on quetiapine if I'm having patients with hallucinations at night and problems with sleep at night. Pimavanserin does not have that degree of sleep problems, or sedating effect as the other 2 medications do. So REM sleep behavior disorders, I told you I wanted to come back to this. This is just a really fascinating problem with Parkinson's disease patients. So again, in REM sleep behavior disorder, you're acting out your dreams. So the semi-paralysis that you see in normal REM sleep actually goes away, and you actually start moving around and fighting like you're acting out your dreams. This is pretty unique to Parkinson's disease and some of the disorders that are similar to Parkinson's disease. When we look underneath a microscope, we see protein deposits called alpha-synuclein and what we call Lewy bodies. We also see these same protein inclusions in a couple other different disorders that are similar to Parkinson's disease, namely MSA and dementia with Lewy bodies. And we see REM sleep behavior disorder in all 3 of these disorders. So it seems to be somewhat unique to the alpha-synucleinopathies, or the disorders that have alpha-synuclein. This is present in Parkinson's disease once you're diagnosed. So as you can see on the slide here, it's about 30 to 50% of Parkinson's patients. But REM sleep behavior disorder is actually the greatest risk factor for developing Parkinson's disease before you start having the motor symptoms. There are estimates now that every year you have pure REM sleep behavior disorder, you have about a 6 to 7% chance of converting from just REM sleep behavior disorder to either Parkinson's disease or one of these associated symptoms or syndromes like MSA or dementia with Lewy bodies. I've seen studies now, 12, 15 years out, where somewhere around 75% of patients at that point have converted from just pure REM sleep behavior disorder to one of these neurodegenerative conditions. The formal diagnosis of REM sleep behavior disorder is made through a sleep study. In my personal clinical practice, I don't use a lot of sleep studies to diagnose REM sleep behavior disorder. That's mostly because I'm seeing patients already with Parkinson's disease. At this point, the cat's kind of already out of the bag. But if you're a patient or a person with just pure REM sleep behavior disorder, or think you might have REM sleep behavior disorder and you have not developed Parkinson's symptoms, I do think that it would be very important to get a sleep study and really confirm whether or not you might have REM sleep behavior disorder. There are lots of trials out there that we've already talked about, and patients that may develop Parkinson's disease later or have a high likelihood of developing Parkinson's disease later are really the types of patients that we want to do our trials on. And it also will help you potentially prepare for the future. We don't have any neuroprotective treatments now, but eating healthy, exercise, those are all very important and may decrease your risk of developing Parkinson's later. Certainly they will slow down the progression potentially of Parkinson's disease. All those things are awfully hard to prove, but being healthy is so important in the Parkinson's disease world that if you have some of these disorders, it kind of gives you another incentive to be healthy and get out there and be active. Unfortunately, REM sleep behavior disorder in our world sometimes has been correlated with worse disease progression. So there does seem to be some things that seem to be associated with REM sleep behavior disorder. And then I just also want to put here on the bottom of the slide that just because you're having symptoms where you seem to be acting out your dreams, that may or may not be REM sleep behavior disorder. There's a lot of other things on a list of possibilities that might be REM sleep behavior disorder. So hallucinations at night, post-traumatic stress disorder, restless legs, periodic movements of sleep, off times at night, sleep apnea, and pure nightmares. All of these potentially could mimic REM sleep behavior disorder. So what do we do about it? So the first thing is, at least from a medical standpoint, is to do nothing. REM sleep behavior disorder does not seem to overly affect sleep quality. Now that being said, you certainly can have a risk of hurting yourself or your spouse. I've seen estimates up to 70-75% of patients have had some type of injury or have hurt their spouse. So it is something to be aware of and to be careful with. It's also been associated with other sleep disorders which could impact your sleep. But the first thing I always start with is lifestyle. So doing something where you're keeping you and your spouse safe. So pillows between you and your spouse, lowering the bed. You can't fall out of the bed if the bed's near the floor. Moving the bed up against a wall, moving away things that you could potentially hit, like a bedside table. Worst case scenario, your spouse may even need to sleep separately from you. Remove exacerbating medications. So antidepressants can definitely increase REM sleep behavior disorder. So either moving them to the morning or eliminating them altogether can be important. And then medication options. Melatonin is something I typically start with. It has less side effects than some of the other drugs on here. Clonazepam is a sedative and a benzodiazepine. As I've written here, it can increase falls and contribute to cognitive impairment. I tend to try and avoid this, but both melatonin and clonazepam have the best evidence for treating REM sleep behavior disorder in the Parkinson's world. I'd tell you the evidence is not overwhelming. Certainly I've seen a lot of benefit in clinic, but there's been actually a couple of higher level trials that have come out recently which have at least questioned how beneficial these medications are. I think time will help clarify things, and again, I've definitely seen benefit in the community and in my clinic, but we don't have a perfect option, I guess is what I'm trying to say. In terms of other medications I have listed on here, memantine or Namenda, which is a cognitive medication, rivastigmine or Exelon, which is also a cognitive medication, and even levodopa potentially could help with REM sleep behavior disorder. I've had many people come in my clinic saying once we get them on levodopa that their dreams get better. Levodopa is probably a little bit controversial. It can affect REM in a negative way as well. But again, I've had a lot of patient stories where they feel like levodopa has helped them. This is a video of REM sleep behavior disorder. I really just wanted you guys to see what we're talking about. I think videos really help. You can see him starting to move around after that could be quite violent. I would not be wanting to sleep with this guy. So he's almost already fallen out of bed. So I mean, this would be a guy that we need to treat. My next couple of slides are looking at things that may or may not be associated with Parkinson's disease. So the relationship between restless leg syndrome and periodic limb movements to sleep is somewhat controversial. The percentages in the Parkinson's world are about 3 to 21%, and in the normal population or the population that doesn't have Parkinson's disease, 3 to 14%. There's a lot of things that potentially could mimic restless legs, so neuropathy, pains at night, just regular nighttime restlessness, dystonia, which is like a twisting type movement we see in Parkinson's disease, oftentimes at night. All of these can look like restless leg syndrome. In terms of treatments, with restless legs, a lot of times we see iron deficiency, so iron supplementation can be helpful. Antidepressants can also worsen restless legs at night, so it's important to recognize that. Our medication treatments typically involve dopamine agonists, which are something we use in Parkinson's disease, so there's probably a similar pathway. And then gabapentin is something else that we use, or gabapentin derivatives. Finally, sleep apnea. So again, the relationship with Parkinson's disease is a little bit controversial. If you look at percentages of sleep apnea in Parkinson's, what I could find is a pretty broad range between 15 and 76%. And if you look at a population without Parkinson's disease, 17% of men and 9% of women between the ages of 50 to 70 also can have sleep apnea. Sleep apnea can actually be quite dangerous. It is something that needs to be treated. We're recognizing more and more that can contribute to cardiovascular issues, so it's definitely something that people should not take lightly. With sleep apnea, a sleep study is diagnostic, and our treatments, there's quite a few now for sleep apnea, but CPAP is probably the mainstay at this point. So my conclusions, I put this in bold: you're not alone. Sleep problems in Parkinson's, again, are very common, and it's not just people with Parkinson's. I struggle with sleep. I know how difficult it is when you can't go back to sleep and you're just kind of lying there. It's really hard. The diagnosis, again, I just wanted to say again that it can be difficult because there's so many different things in the Parkinson's world that contribute to sleep in a negative way. And when we're going through a review, we want to make sure we look at other medical conditions. We want to make sure that we look at medications that are not specifically geared towards Parkinson's disease, because again, everything is not just from your Parkinson's disease. There can be other things that can contribute to issues that we see in the Parkinson's world. We have a lot of different strategies. We have both medication strategies and non-medication strategies. Again, with the medication strategies, unfortunately, we just don't have the high-level evidence that we'd like to treat sleep in Parkinson's disease. Then I just want to say again that treatment can be difficult when you're trying to treat sleep in Parkinson's because of the complex nature of the issues we face.